Thank you very much for your warm introduction. And I wanted to say how grateful I am to be invited to speak at this session. I think the thing I wanted to point out was an international meeting like this is a great way of sharing ideas. And one of the themes that is central to the presentation I'd like to give today is about how siloed we are, siloed as clinicians, siloed in the laboratory, siloed internationally. And it's meetings like this that allows us to think differently about what it is that we're currently doing. And so that's what I'd like to touch on. I was asked to speak about Australia and antimicrobial stewardship, and I will give a very brief overview of it because I think Australia is in a very comfortable position at the moment in terms of international support for the antimicrobial stewardship program. And I'll run through, and I've given you some links in this talk. But what I'd really like to focus on is the particular interest that I have, which is about the issue of diagnosis that was touched on by Dr. Shoten earlier, and where we could perhaps change our thinking a little bit and put more emphasis on the diagnostic process and maybe balance it up against our focus on antibiotics or put them two together. So firstly, to start off on about Australia. So Australia has a nationally endorsed antimicrobial resistance and stewardship strategy, which has just been updated. And you can see that what's being proposed in Australia, or what's actually being implemented in Australia, is very much along the lines of what most countries would dream of having for an antimicrobial stewardship program, where there's clear governance over antimicrobial resistance and stewardship, which happens in Australia, and that it's linked in with prevention of infection and control of resistances, and that it's got representation out to public and promotion out to the public. It focuses on appropriate usage and practices, and that it focuses, so in altogether we're blending antimicrobial stewardship in with antimicrobial resistance, and it has an overarching governance within the government, and that there's a collaborative research agenda, and that it works very much across boundaries in international collaborations as well. So this is an outline of the different streams of antimicrobial stewardship. I'm going to focus particularly on hospitals, but to let you know, in the last 2 years, there's also been incorporation of antimicrobial stewardship for surgery and antimicrobial stewardship in aged care, so outside of the hospital and in the community as well. But for the purposes of this talk, I'll limit it to the hospital one. So there is 3 programs that run together. So the AURA one is the one that that looks at antimicrobial use and resistance. The NAPS program is the prescribing surveillance, and I'll present some of that data later on in the presentation. And then there's the National Antibiotic Utilization Surveillance Program. So the links are on this slide down at the bottom, and I really encourage you to have a look at them because all of that information is freely available, and you can look at it in detail. So it does tie in very much with the Netherlands experience, but Australia is doing very well at implementing it at a national level. A key component to this is that antimicrobial stewardship actually sits within the hospital accreditation requirements. So in Australia, you cannot function as a hospital without running an antimicrobial stewardship program. And so it is incorporated into the other safety and quality areas within the national standards. So there's national safety and quality healthcare standards, and standard 2 of those healthcare standards focuses on infection prevention and antimicrobial stewardship. And importantly, that is more than a mission statement. There are specific requirements, and there's a specific process at accreditation. So when a hospital is inspected to ensure that it remains qualified to continue caring, there is one of the 8 streams requires that they meet the required criteria and specific assessment of adherence to the recommendations within the hospital. So that has really given teeth to the antimicrobial stewardship program in Australia, and it's a very smart program. And so I've got some of the outcomes, but I co-authored the chapter. So there's a book that has been released, which is the Antimicrobial Stewardship in Australian Healthcare. It's all freely available. And chapter 9 is looking at the role of the clinical microbiology laboratory in antimicrobial stewardship. What I will do is I'll go through and show which of those I'd like to focus on, and particularly those ones I'm focusing on is how the laboratory engages with clinicians, rather than what the responsibility is for the laboratory. So for a long time we've known, and when we speak about microbiology in antimicrobial stewardship, we'll often talk about producing antibiograms, doing rapid diagnostic testing, making sure there's adequate standards for antimicrobial susceptibility testing, and that there's a reporting of antimicrobial resistance. They're all the sorts of things which are within the remit of the laboratory and really shouldn't be they're not things that clinicians need to think about particularly. But in this edition of the booklet, we put in a lot more information about the areas which are of relevant to clinicians, and that's what I will be looking at in terms of how clinicians use the tests, and also how do they order them, how do they collect them, and then how do they interpret the results. I'm going to do, and this is where Australia stands at the moment with regards to antimicrobial stewardship. So the most recent prevalence. So every year, and it will be in this week of the Antimicrobial Stewardship Week, there is an annual survey, and in the survey there is it's a prevalence survey where they look at all the prescriptions of antibiotics in the hospitals. So in 2018, and this is the most recent report that's been published in 2020, is the 2018 survey, and in that there was 26.7 thousand prescriptions that were looked at in 324 hospitals across Australia. And there's very, very detailed information that's collected according to the criteria that are set out for antimicrobial stewardship in the safety and quality guidelines. So they blend together. And what we've seen over the years, so we've had surveys going since 2018 to 2015, we've seen total usage in Australia remains high, and there have been some improvements, but they've not been overwhelming. And the appropriateness for prescribing is sitting at around 77.7%. But we have seen antimicrobial stewardship programs routinely implemented. We're seeing some improvements in some of the process measures, so reduction in prolonged prophylactic antibiotics, better documentation of the reasoning for antibiotics. But as per most international programs, there is difficulty in correlating the improvements in the process measures to better outcomes for patients. So back to our silos again. So the first silo I'd like to touch on is to think about how a patient who's presenting with an infection or sepsis, this is noisy, but I'll try and break it down. And the noise is there for a reason. But we see a patient who presents to hospital with symptoms and signs, has a provisional diagnosis, might receive a preliminary microbiological diagnosis, and then there's maybe a final microbiological diagnosis, and then ongoing management and discharge. And in this time, the patient might go from primary care to the emergency department, to intensive care or the acute management unit, through to general wards, maybe through to rehabilitation and out to primary care. So we look at many transitions of care over this time. And interestingly, if we break it down, I'll highlight these are the bits that relate to the laboratory, and these are the bits that relate to the clinicians. So the clinicians come along here and they will do hopefully an initial assessment and a physical examination. They'll make a presumptive diagnosis. They might decide what tests are to be ordered. This is the provisional clinical diagnosis. The tests are collected and sent off to the laboratory. And one of the things we know with microbiology, it's not like a troponin. The results come back over time. And we're never sure when they're quite going to come back over time, because it depends when the cultures are positive and when the laboratory reports them out. So we see them trickle back over days. And so there's this very complex interaction in this period here where we need the results read and interpreted and acted upon. And so in amongst this, we try and change our management. So we have empirical treatment here. So there's a resuscitation done and the decision-making about which antibiotics as well as which tests to use. Should be a reevaluated, definitive treatment, secondary prevention. So as much as this chart is messy, it probably is an underestimate of how complex care of patient is because of these transitions in care, because decisions are actually being made and revised over a period of time. And I think until we can begin to encompass this and think about this in our approaches to antimicrobial stewardship, we are going to be facing troubles. So the other thing that I reflect on as I think about the times of antimicrobial stewardship is that over the same time that we've seen antimicrobial stewardship gain in awareness and be implemented, we've actually got a surviving sepsis campaign, which has gone along at the same time. So we've had about 25 years since antimicrobial stewardship was first mentioned in PubMed, and it's 20 years since the first international sepsis working group was gathered as well. And we've got these key recommendations from antimicrobial stewardship is that we should use antibiotics judiciously. They should be driven by guidelines, decision support, narrow spectrum, documentation and review. And we've got measurement systems of, like we've talked about in the Australian, of measuring antimicrobial resistance, looking at antimicrobial, looking at the quality of use, looking at the total antibiotics used. And at the same time, we've had very, very countering messages of the sepsis campaigns of that we need to avoid delays in recognition. So these are dependent on sepsis bundles and these screening tools. And the screening tools are being mistaken for diagnosis. And then we've also got this pressure coming from surviving sepsis that we need rapid intervention. So we need to give broad spectrum antibiotics quickly, increasingly quickly. And we have got what's stuck in our clinicians' mind and is being still sent out is this message from 2006, the Kumar paper, which says that each hour in delaying or administrating antibiotics decreases survival from sepsis by 7.6%. Now, this has been soundly criticised and is probably should be dismissed as unfounded evidence now. This was a group of patients that were in hypotensive shock in intensive care, and even allowing, and so what happens is people have extrapolated hypotensive shock to any patient with a cold in the emergency department. So we've got a diluting of the message here, and there's been very good evidence since then that have dismissed this as being an accurate, real representation. So as long as we've got the sepsis voice, which is probably louder and more appealing to clinicians, saying that broad spectrum antibiotics should be given in less than an hour, and we've got this antimicrobial stewardship saying antibiotics are precious, we've got a conflict here. What's more, we've talked a little bit about what measurement systems we use and what progress we're making in antimicrobial stewardship. Well, as in the sepsis field, they can produce, the sepsis researchers can produce evidence that sepsis rates, sepsis mortality is plummeting since the advent of the Surviving Sepsis campaign. So I think it's important for us when we have these discussions that we think about in another room, in another conference, somewhere else around the world, and in, education campaigns for nurses, doctors, pharmacists. There's messages about giving antibiotics, any antibiotic quickly to save lives versus perhaps our more sturdily evidence-based physicianly approach to please be judicious, use them wisely. And I think they're in conflict. It's also important to remember that our strategies, whether it's antimicrobial stewardship or surviving sepsis, are very much at this line where all of the intervention is focusing on giving antibiotics. And the question remains is there room for thinking about how much more we should be doing in more accurate diagnosis and aiming for a greater proportion of microbiological diagnosis. And if we put our emphasis in that, would we have a way of blending the sepsis messages and the antimicrobial stewardship messages? So I'm just going to touch on that again. This is my segue slide. These are wheat silos that are in Western Australia's country, where there's been a campaign over the last 5 years to paint the silos, and there's these very impressive pieces of art, in my opinion, that make a nice segue for our bits in this talk. So what I'm just going to talk about for a minute is what the evidence from the sepsis world is telling clinicians and telling us. So Chinu Ree is probably one of the great writers in this area, in my opinion. And he's done some very nice work, which has shown that over the time since the sepsis campaigns were released, we've seen a incremental rise in the diagnosis given of patients as sepsis, but we've seen a corresponding decline in specific diagnoses, because remember, sepsis, you can have pneumonia with sepsis, you can have intra-abdominal infection with sepsis. Sepsis is a physiological parameter which is used as a screening tool to pick up those people that are at high risk of mortality. So we've got this very messy term of sepsis in here, which is poorly defined, and it seems to be replacing specific diagnoses. So in this same time that we've seen a reduction in specific diagnoses of types of infection, there's been a flat line in bacteremia rates. And this has been shown in another paper that he looked at, and more specifically to our discussion today, is that as we've seen rates of septicemia, these different lines are different ways that you capture septicemia in administrative coding data. And these are bloodstream infections from the same period. So in fact, there's been a reduction of confirmed bloodstream infections over the same time that we've seen the rates of sepsis increasing. So either that increase in sepsis is a fallacy, or blood cultures aren't being used well, that we're underdiagnosing people because we're not focusing on that, or perhaps a combination of both, or perhaps a third that we don't yet understand. This is his more recent paper from 2020, where he's looked at the issue of coding, because it seems to be that when we're measuring sepsis by coding data, which is probably the equivalent of measuring antimicrobial stewardship by antibiotic usage rates, they're not accurate indicators of what's happening with individual patients. But if we look at implicit sepsis codes, these have skyrocketed. And if we look at mortality rates, so remember the Surviving Sepsis campaign can and does celebrate that there's been a drastic reduction in deaths, mortality from sepsis over this time. And what's argued in this work is that, in fact, what we're seeing is it's a bit like prostate cancer. If we screen for prostate cancer and diagnose asymptomatic patients who might not have progressed, that you will see a decrease in mortality, not because the interventions are more effective, but because we've changed our measuring. So I won't go into this in detail, but I think this paper is a lovely paper that talks about what are the potential biases looking at the incidence and mortality of that. There's a bias in the awareness campaigns and the screening protocols, which is going to lead to upcoding and up-labeling of patients as having sepsis, which does not correspond with the disease in patients. So I refer to that paper with interest. I think if we scratch under the surface, we can see some other interesting information coming out of this work and from even the Australian prevalence study. But this is a nice paper which looks at the likelihood of a confirmed infection or a probability of infection in patients admitted to intensive care with presumed sepsis. And when they looked at a retrospective analysis of those cases down the track, up to 40% of patients admitted to the intensive care units with a working diagnosis of sepsis turned out to have a low probability of infection. So we've got 10% here that had no chance that they had infection, so they were misdiagnosed as infection. And then there's this other 30% group in here where it was possible but thought to be unlikely. So I think these are important messages for us to take home, and I think there's an equivalent in antimicrobial stewardship. So this is one of a favorite paper from Felici from 2015. What he did in this paper, what he and his group did in this paper was looked at, the original paper from this was a computer decision support, looking at the effectiveness of computer decision support in antimicrobial stewardship. And what they looked back at is they went to those patients who'd had these decision trees aligned to them. And of the 500 patients in that study, only 55% the diagnosis was correct. So almost 50% of patients did not have the correct diagnosis. And importantly, 33% of them, no antibiotic was indicated. So as long as antimicrobial stewardship is focusing on following guidelines and computer decision support, at that point, we if it's not evidence-based, if there's not a microbiological diagnosis, one of the issues is we could have people having 100% compliance to guidelines, but if their initial diagnosis was wrong and they've been given antibiotics for pneumonia when they really have got Staph aureus septicemia, then the benefit of the guidelines and that approach to stewardship is flawed. So this was a very interesting paper because it points out that the rates of diagnostic error is 2 times higher than for other diagnostic error rates in general inpatients, so diagnosing heart attacks, diagnosing other diseases. When it comes to infection, the error rate is twice as high. So I'm going to go back. I said I'd come back to the Australian National Antimicrobial Prescribing Survey. And one of the parameters they look at is what's the compliance with guidelines and prescription appropriateness. And directed therapy is where the treatment is being given according to a confirmed microbiology result. And this generally sits at about 13%. And if we look at it over time, since 2013, there has been a bit of an improvement. So from 9.5 up to 13.6. But what this means is that we've got 86% of patients which are being given empirical therapy. When we look at that more closely, so this is a detail of that data. So this is the prescribing survey of all of the hospitals in Australia from 2018. And it's broken down by whether it's guideline-based or whether it's really hard, whether it's guideline-based. And what we're looking at in particular is where it's directed therapy. So this army green color is directed therapy. So there's some here that we'd expect, like pneumonia is very hard to get a diagnostic test. So we might expect those to have a low rate of directed therapy. But what I find is very interesting is when we look at the group that the patients have been labeled as sepsis, in that case, only 20% have got a proportion of directed therapy. So we've got this other group where there is no confirmed diagnosis, and what should have a relatively high rate of microbiological diagnosis like pyelonephritis or cystitis. What we see in this group is that, again, we've got a small proportion that have got a confirmed microbiological diagnosis. Now, some of this could be that the prevalence survey was done on the day that the patient was admitted, so those results weren't available. So there could be other explanations. But the question I put forward to our group and to our community is this acceptable? Should we be looking more closely at what proportion of our patients do we ever get to have a final diagnosis, to be able to look back to see if they were diagnosed correctly? And is that something that should be the focus of our antimicrobial stewardship programs, is looking at the diagnosis process and looking at some quality indicators around how we're using tests and how effectively we're using tests. And this is just reiterating the point that if the diagnosis is wrong, following guidelines is going to be fraught. And the effectiveness will be lost and even harmful if they follow a guideline when the patient has an alternative, diagnosis. And the other one I'd put in here is there a possibility that incorrect use of microbiology tests can contribute to diagnostic error? So if a blood culture is collected or a diagnostic test is collected after the patient's been given antibiotics, does that mean that that's my alarm going off for the previous closing time. Does that mean that we could cause harm if the test was done after the patient had antibiotics, and people interpret that as being a negative result? And so then the thought is that the patient doesn't have septicemia when in fact they did, but the reason they didn't have it was because the test wasn't done correctly. Could it even be that a contaminated sample is being treated? So again, just to point out, these are the typical things. These are all of the parts of the role of the laboratory that are very much internally focused for the laboratory. But what we wanted to touch on briefly, as I will be in this last portion of the talk, is talking about some of the evidence that we might have, or thinking about what are this is the interface between the silo of the laboratory and the clinicians. So does the laboratory play a role in helping make sure that clinicians use the tests properly, that they collect them properly, and that they understand the results and act on them when they come back? Again, this is pointing out that a lot of our focus is here for stewardship and sepsis. So what can we do in this space here that's looking at the use of tests, and could that be improved? So microbiology is somewhat complex. It's very different to doing a sodium where you get a quantitative result back. Microbiology is very much rubbish in, rubbish out. If you don't collect your samples properly and you get contaminated samples, or you get negative samples, that will reflect on the collection, not the status of the patient. This is a project that I'm leading at the moment, which is looking at the issue of, can we use laboratory data to tell us about how effectively tests are being used? And it's designed as an interdisciplinary data-driven quality improvement program that's trying to look at outcomes. So can we get outcomes? And so for blood cultures, that's an interesting one because we can look at whether the diagnosis, whether the blood cultures are positive or not. Can we use this interdisciplinary data-driven system to bring about organizational change? And does this introduce new ways of learning, much along the lines that was discussed previously about multidisciplinary care data, learning from each case as it comes through? So this is a large group of people from different areas of expertise, clinicians from across the state, that allows us to benchmark between the states. We've got consumer representatives, we've got data scientists, we've got implementation scientists, and the representation. So from that, we come out with some pretty basic graphs, but this is information that we don't necessarily tap into. This is the use of blood cultures in Western Australia from all of the public hospitals. So there's 94 different hospital sites. This is information that can be extracted from any information system with some manipulation to be able to take raw laboratory data and make it useful in this setting. And what we're looking at is who are the patients that are getting tested and looking at what the results are. But aside from the organisms, what we're particularly interested in is performance metrics. So for those of you that are aware of the evidence base for blood cultures, remember, even if we're doing rapid diagnostics, it still requires that you test the right patient and do the right tests appropriately. And then the rapid tests are done once a blood culture is positive. So this is looking at the requirement that for a blood culture, the difference between collection of one test and two tests. And the idea is that 2 blood cultures should be collected sequentially before you start your antibiotics. When we compare 4 different sites within the data set, we've got one site where they're collecting 2 sets within an hour in 40% of cases, down to another site where this is a pediatric site. So that's our exclusion, because we don't expect 2 sets from kids. But we go down to we've seen some improvement over recent years, up to 29%, but we've got a long way to go before every patient coming to the emergency department with suspected sepsis gets, if they're going to have 1, they should have 2. We also, within this system, have the ability to look at contamination. So blood culture contamination is an interesting one because that's a misdiagnosis or a missed opportunity for diagnosis. And it's also got cost implications for the health system as well, which is a good way to look at sustainability. I've also been exploring other ways to look at markers of urine contamination. That's another issue that we have, that urines are contaminated at the time of collection. So this is a prototype of looking at some preliminary data of comparing rates of contamination between different wards in a hospital in terms of high levels of epithelial cells, moderate levels of epithelial cells, and urines that have white cells but no epithelial cells. Similarly, for wound swabs, we have the ability to look at wound swabs to see whether they grow mixed organisms or whether they've got leukocytes in them. So can we use this as information that tells us that people are using diagnostic tests incorrectly, and that may contribute to misdiagnosis? We also look at repeat testing. So this is a rank of the patients that have, the number of tests that a patient's had. So in this one site, we had one patient who had 59 blood cultures in an admission. Now, it might have been a long admission and they might have had repeat episodes, but 59 seems an awful lot. And this is urine tests and wound swabs. So do we really know what's going on in the laboratory? And is this what's going on with laboratory diagnostics? We know a lot about what's going on in the laboratory, but do we know a lot about how clinicians are using diagnostics? So I'm going to wind up here by talking a little bit about a survey that we conducted, asking our doctors and nurses about questions of, do they know about best practice use of microbiology tests. So this one's about blood cultures, and we asked them, when you're collecting blood cultures, how important is it to collect the antibiotics before antibiotics? So that got a high rating. The number of sets of blood cultures, interestingly, 30% were unsure or didn't think it was important. And we know that there's the evidence says 25% increased yield if you collect 2. Looking right down to what's the correct volume, and we would expect that our clinicians would know that the correct volume to put in each blood culture bottle is 10 mils, but this only accounted for 65% of people. Similarly for urine, so we know that urine shouldn't be routinely collected on admission, but that's not reflected when we ask clinicians if they know this information. Should preoperative screening be done? No, not unless there's only 2 operations for which it's indicated. Patients with catheters, the routine use of blood cultures for somebody with confusion may also be an overuse and incorrect use. Similarly, why would 40% of patients who have cellulitis without discharge, why would they have a wound swab? What's the purpose of doing a wound swab? A non-healing wound, the purpose of doing a wound swab for a non-healing wound, a typical microculture sensitivity is unknown. I think this is one of the real take-home points that I'd like to be finishing up on, is when we asked them, so we asked them all these questions about, there were more than I've presented here, about their knowledge of applications of microbiology tests. And then we asked them, have you had formal training in microbiology culture test use? And the doctors come out and 60% of them say yes, but we've got 43% who are saying no. And it's even more alarming for nurses. So when we're thinking about antimicrobial stewardship, should we be including more information about diagnosis in our training? These are some graphics that we did for producing a very visual, easy to use guidelines and short sets of movies. I think I've put the URL for the movies there that shows them how to use the tests and why, and how to read them and interpret them. We also looked at some very visual guidelines here. So this is a printable guideline for how to use blood cultures, urines, and wound swabs, because they're the most common, and a guideline for patients on collecting self-collected urine samples. So this is a real whirlwind tour, and we're running over time, and apologies for that. But what I'm trying to do is thinking about the processes of care that's involved in antimicrobial stewardship, and thinking about antimicrobial stewardship from a patient management and a patient outcome. So we do a lot of focus on counting prescriptions and counting antibiotics. The question is, are we doing enough on counting patients and measuring the quality of care for each patient coming through? And are we cognizant of the very mixed message that clinicians are getting in this space? So I hope, and I look forward to learning more. It was great to hear about what's happening in Netherlands. I look forward to the other speakers coming along, but I hope I've planted some seeds about the role that the microbiology laboratory could play going forward, and a potential way that we can get good sources of data for our antimicrobial stewardship set without needing to do audits. So thank you very much for your time.